Bern. I'm calling in from Bern, where I work at the Bern University of Applied Science as a lecturer and also in research. Together with my colleague, Caroline Dixon, I'm leading the webinar series. And maybe, Caroline, would you like to introduce yourself?
Hi, thanks, Christoph. I'd just like to say hello, I'm Caroline from Edinburgh. I'm an honorary lecturer at Queen Margaret University, and as Christoph says, one of the European directors of the ICoP. So we're really happy that you're here with us today.
Yes, and there will be 4 webinars each year that are accessible to ICoP members. This is the second one, and we hope the timing is acceptable for you wherever you are, but we will evaluate that as we progress through the series. The purpose of the series is to connect you, the global ICoP community, by sharing and discussing innovations in the field of person-centered practice and providing a platform for members to share development projects, research, and scholarly work. With that in mind, Caroline and I really welcome ideas from members for topics for future events. Please do not hesitate to get in touch with us, send us an email or call us, however. And we would also like to encourage you to promote these webinars and encourage colleagues from your networks to join us via the PCP website. Yes, and for this webinar, we have slightly changed the format. The webinar will last, like last time, 1.5 hours. First, we will give you the opportunity to introduce yourself and connect with others in small groups by sending you to breakout rooms. Then there will be a presentation, followed by another discussion in small groups based on 2 questions. Finally, we will have an exchange with all participants. Caroline, do you have to add something? It's okay, good. So, therefore, we would love to give you first 10 minutes to check in and exchange in small groups. And in person-centered practice settings, we love to use metaphors for this purpose. You could talk about your favorite holiday destination or something you experienced today that made you happy to get into connection and to exchange. So we send you now in these breakout rooms, and I'm happy to see you back here in 10 minutes.
So Shima, are you able to pop everybody into small groups for us? Thank you.
Yeah, I'm just going to assign people to breakout rooms now.
Will take a moment, I think. So I think you are on your virtual way now. Takes a moment to find the path.
Are we going, or we're all still here?
Sorry, just 1 second. It's just going a little slow.
Technology is wonderful when it works smoothly.
Yes. Yeah.
Well, Michelle, don't leave. Maybe stay for the presentation, even if you can't interact with others. That's Michelle Croston.
No, I think it starts with yes.
Okay, people are going into their breakout rooms now.
maybe you could bring them out a little bit earlier, maybe. So for the ones who came new now, we would record the session. We are happy to see your face, to see your smiley face also. And if you don't like that, if you don't want, please turn off your camera. Yes, now we come to the topic from today. It's the lean methodology, and here in Switzerland, lean methodology is commonly used to develop processes in healthcare institutions. However, some of the institutions are questioning how to integrate this philosophy within person-centered practice. Is it possible, and if so, how? Yes, to answer these questions, we are really excited to welcome Dr. Jean-Paul Thieling. He developed the person-centered Lean Six Sigma model, which exactly does that, bringing together lean and person-centered practice. Dr. Jean-Paul Thieling is a lecturer and practitioner in process improvement at UCD Health Systems, University College in Dublin, Ireland, with research and teaching grounded in systems thinking. His work emphasizes the real-world application and implications for professional practice of concepts, including Lean Six Sigma, person-centered cultures, and collaborative practice. His background is in nursing, pediatric nursing, clinical project management, and quality improvement. And he holds teaching excellence awards at both college and university level, and is a UCD fellow in teaching and academic development. Yes, Jean-Paul will speak for around about 35 minutes, and then we will open the breakout rooms again for discussion in small groups. And now, thank you very much, Jean-Paul, that you're here. We are really excited, and the stage is yours.
Thank you so much, Christoph, and thanks so much, Caroline and Shima, and lovely to see some familiar faces here. And thanks very much for coming. And it's great to actually be speaking to a group of people who are working with person-centered approaches. Sometimes I don't just have to start off talking about what lean is. I have to start explaining what we mean by person-centered, or what my interpretation is. So it's actually fantastic to have a team of like-minded people in the room. So thank you very much. I'm really delighted to be here today. So I'm just going to tell you a little bit about the work that we've been carrying out over the last number of years. So first of all, I really have to say that this started off as I was working in process improvement for about 11 or 12 years, using predominantly Lean and Six Sigma, model for improvement, different models. Always felt as if something was missing. And really just couldn't put my finger on it. I was aware of person-centeredness through work that was done in nursing, but I wasn't actually working in nursing at the time. I was working in quality improvement and project management. But I was aware of work that was done obviously by Brendan and Tanya in particular, through our nursing colleagues in the hospitals I was working with. I suppose at that stage then, Michelle Hardman, who's here, good morning, Michelle, invited me to speak at a conference in Galway, and it was about improvement up in the Galway clinic up in Ireland, up the west of Ireland. And when I was at that, I had the pleasure of meeting Jan Dewing, and we were sitting down chatting at the conference dinner, as one does, and I was telling her, you know, there's something missing here. And then I heard Jan speaking the next day, and I thought, well, that's what's missing. It's very technical. It's just not person-centered. It doesn't sit right with me, the way we're using improvement. So Jan said to me, there's a PhD in that. And I went straight back to my CEO, who actually knew Jan from work herself and Brendan had done with nursing in one of our hospitals. And she said, oh yeah, no problem. Great, let's go. So that was sort of the genesis of my journey, which was very, very serendipitous that Michelle happened to invite me, that it was the right place at the right time. So that was really the beginning of the journey, but I do very much feel as if it was a meant to be. So this is really the work of myself, Jan Dewing, and Dr. Deborah Baldy, who a lot of you will know as well. Deborah and myself, Debbie and myself, are continuing to collaborate. We have another paper coming out, 2 more papers on the model coming out shortly. hopefully to, and I'll talk to you a bit more about those now in a moment. So basically just, I suppose, the context, and you'll all be aware of this really, you know, we're working in a system with disparities in access to healthcare. You know, the costs of care continue to rise and spiral. The demographic shifts, as we all know, we've an older population internationally. In Ireland, we've got a very young population, very old population. In fact, we sort of joke sometimes that what you call it, some of the most lucrative businesses, and I don't like to use it like that, in Ireland at the moment, are creches or childcare and care of the elderly. So we've seen those demographic shifts and the challenges they bring as well. Obviously, the pandemic obviously had a huge impact on staff morale and well-being, as well as obviously the general public. But also it's put more pressure on the service you work in. So, for example, there's 26 million elective surgery appointments, or therapy appointments were cancelled internationally, if not more, if you include all the diagnostic procedures. So we have waiting lists already internationally for treatment, and now they're even bigger. So the pressure is on staff to deliver on the service that was already under huge pressure. So these are the type of contexts we're working in. We all know about the workforce shortages that are there as well. And of course, there's technological advances. Now, I'm working with a lot of hospitals on, for example, electronic patient records, which are fantastic things. But one of the key things is that we have to remember that with technology come challenges, staff competency, staff training, staff being comfortable with using technology. So that brings its own challenges as well. But all of these issues, I had the pleasure of speaking last week at the Sláinte Care conference in Ireland, nursing conference. And Sláinte Care is like one of our main healthcare funders. And it was very clear we had about 800 attendees at that, and it was very clear from the audience that these are the type of pressures that are being felt by, they were an audience of nurses and midwives, but the pressures that are being felt in the system at the moment. So in reaction to these challenges over the years, there is a bit of give me something, give me a panacea, let me solve these problems. So, we're using like the model for improvement, or Lean, or Six Sigma, or Lean Six Sigma, or Agile, or the project manager's book of knowledge, or, you name it, you could have Prince 2. There's lots of different methodologies out there, obviously. And often we're just doing sticking plaster, just throw that at it, use that'll work. And we can use them in a very technical manner and apply them in a very prescriptive manner to try and get results quickly. So this can obviously have impacts as well on staff and how they're used. So if you look at the literature, you look internationally, the commonly most used approaches to try and have improvement are Lean and Six Sigma, and then obviously with WHO and the IHI are advocating person-centeredness as well. But do they sit well? And this was the question we were asking at the time. Is there any synergy between these approaches to improvement or not? And how could we have, as Christoph was saying, how could we have person-centered approaches? So basically, in a nutshell, just I don't want to dive too much into the technicality, but basically Lean Six Sigma is a hybrid of two process improvement methodologies, both of which come from industry, one from Toyota motor industry and one from Motorola, with a strong focus on the patient, the employee, management support, and teamwork. So there seems to be a lot of things in there that would indicate, yeah, these will work very well. And they talk about removing what we call non-value add. So when we talk about non-value add, what does that look like in healthcare? So here's a picture in the middle of my mum. She's passed away now, unfortunately. She appears in every presentation I've ever done. But Betty was 83 when she fractured her hip. And these were the touch points of the people who interacted with her. Not a process map, but all the people who touched her journey during her care of her fractured hip. And I was able, very fortunately, because I was working with one of these hospitals where she had her treatment, to follow her pathway through. So she's registered by registration staff who interact with her, and then there's bloods and ECGs and the triage RNs, and then the emergency team see her, and then it's diagnostics, obviously, for check x-rays. Then she's referred to orthopedic team, and then she's supported because there's no bed available. So she's waiting in the emergency department until she can go and have her surgery with all your anesthetists and anesthetic nurses and PACU nurses and surgeons, everybody there. Then spends a lot of interaction, obviously, with physios and OTs. And then there's the general services, the food, nutrition, the cleaning her bed space, etc. And then it's out to the community. So in Betty's journey, 118 people touched her journey at any one point in time. And some people interacted more or touched her journey more. And non-value add can occur at any place, because really, as you'll all know, healthcare is like a series of dominoes. So if she's not registered, she won't have a medical record number, so they can't start triaging. Then they can't refer to the emergency physician team. The orthopedic team won't make a decision on the fractured hip until they have the x-rays. So if there's any delay there, it's going to cause a problem, obviously. If there's no theatre slot available, she may go straight to the ward, but is there a bed at ward level? How long is she going to stay in the emergency department? Now, we have very long trolley waits in Ireland. I sometimes look at the NHS figures and go, they think that's bad. You want to see, like, you could have patients for 48 hours on a trolley waiting for a bed in Ireland. And if you consider that a hip fracture is meant to get to theatre within 48 hours, international best practice, you can see where the problems start to occur. So this is what non-value add looks like. And what does non-value add look like for our patients? Well, these are 35 patients who are having cataracts surgery, who I had the pleasure of interviewing last year. And you can see that patients feel this weight in the system as well. So if you have a cataract, you're waiting for your OPD appointment, and then you've your waiting time in the clinic, and then your waiting time for pre-op assessment, and then there's the times of the clinics. Like, patients were saying to me, why are the clinics at 8 o'clock in the morning? I'm over 80. The demographic for cataracts is over 80. I live alone. I have to put my eye drops in. I have to try and get to the hospital for 8 o'clock. Why are those clinics at that time of the morning? What say do we have in this? The timeliness of the information, the time spent with the clinician, and then the wait time for surgery. And then because it's cataracts, they have to go through the whole rigmarole, as we say in Ireland, again. So there's lots of non-value add there for patients and for staff. And then we talk about person-centeredness. So what is person-centeredness? Well, my students would have all their own different versions of what person-centeredness is. Now, there are official definitions of person-centeredness, but everybody has their own sense, their own inner feeling of what person-centeredness is. And these are just some of my students felt person-centeredness addressed on the left-hand side. And on the right-hand side, my best definition of person-centeredness is when my mum passed away and I was with her, and I was the only member of my family living in Ireland. I was with her by myself. I didn't press the bell for about 10 minutes. And then when I did, I knew once I pressed that bell, I knew everything would start. So I just sat with her. And then when I pressed the bell, 2 nurses came in. One nurse went to my mum, and the other nurse, who I still remember to this day, Aisling, came over to me and she just gave me a hug. So to me, that was person-centered care, because she just knew instinctively what she needed to do. She had a relationship with me as a relative, as a son, and she knew that I was tactile, so she felt comfortable to do that. But that was just the right thing at the right time. So for me, that was a person-centered moment. But we all have our own definitions, and of course, I'm a bit embarrassed that Tanya's in the room. But this is the definition that I would work off, and that I would encourage my students to work off, and that the whole model that I'm going to talk through is developed around. And you all know this approach of including everybody who's involved in the pathway. So really building on those touch points, anybody who's touching that process is involved in the care and needs to be included in discussions and needs to have a voice. So very much this definition really just aligns with the thinking of improvement in that regard. There is one thing, I'm just throwing this up from Stephen's work, just to, I know you all know this, but one of the favorite phrases I have is from Brendan when he talks about patient-centeredness masquerading as person-centeredness. And I have to be honest, I work all over the country. I work with about 52 hospitals around Ireland, and people say, oh, we're very person-centered, and actually they are very patient-centered, but they are not person-centered, and you can see that, because one of the things that you find in improvement is that lean is pushing to we got to get a result, and so is Six Sigma, where person-centeredness is more about personhood and having an understanding of the person. But very often what you see is we make things better for patients by making them worse for staff. So the question I would ask is, and we'd be asking this model, is how is that person-centered? By making staff who are working under those pressures I spoke about earlier, by making staff who are already at breaking points, just giving them more to do, because that reduces the time they have to spend on quality care for the patient. So for example, I was teaching yesterday, and some of my doctors, students in the class who are doctors, were saying to me, in our clinic, when patients come to our clinic, hospital, we were told that 30 minutes for a patient who's returning, or 15 minutes for a patient who's returning, and 30 minutes for a patient who's new. And they were saying, but by the time the patient comes in and sits down and introduces themselves, and I introduce myself and we talk about the weather and get them comfortable, we're at 20 minutes. So how can we do an assessment in 15 minutes for a return patient? They're saying it's just, we create these metrics that are design our service to fail, and we try and adhere to them. And all that does is make us unhappy as staff because we can't spend quality time with our patients, but also make patients feel hard done by because they don't get to spend enough time with the clinician. They may spend 4 hours waiting for 6 minutes of a time with a clinician. And where's the value in that? So how do we make that more person-centered? So we very much carried out a collaborative, inclusive and participative study, working with obviously the Centre for Person-Centered Practice in QMU, where I was doing my PhD, and then with UCD, we had our curriculum there, our Lean Six Sigma curriculum. We had a study site of major trauma hospital in Ireland, Malta Hospital, and a private study site of the Beacon Hospital. And then when we had when the PhD was finished, we rolled it out to a further 10 sites in Ireland, and then to a further 12. And we used community sites as well for a large scale ophthalmology project we carried out as well. So that's sort of where we were at. And what we did was we spent 13 months looking through the literature. This was meant to be initial scoping review, but we spent 13 months looking at the synergies and divergences between Lean, Six Sigma and person-centeredness. What we were able to develop was a framework looking at where the methodologies were synergistic, where we knew they would align and work well together, where they were influenced by quality, where quality became more of a metric than actually a quality, more of an indicator than actually an experience, and where they were very clearly divergent. And that enabled us to start to synthesize that. So we had this rough model, and then we wanted to do a realist review of the literature. So basically, for those of you who aren't realist researchers, in a nutshell, it's asking why an intervention, in this case, the intervention of Lean Six Sigma, interventions or improvement, what about them worked, in what contexts, for whom and why? So what we did was we were able to look through the literature and do a full realist review on that and develop some program theories as to why we thought that worked. And then what we did from this, we were able to develop 3 pillars, no surprise to any of you: Lean Six Sigma and patients, Lean Six Sigma and staff, and Lean Six Sigma and the organization. Now, for my PhD, I specifically focused on Lean Six Sigma and staff. You may ask why. Because the reason why was because, and our rationale was, when we looked at Lean Six Sigma and patients, really the patient experiences were dependent on the quality of the staff who were using the methodology and how they used it. So we wanted to look at staff first, and then the organization as well. We wanted to look at how staff within organizations would use it. So which is good in a way. We have 2 further PhDs now have sprung up out of my own PhD, one of which is looking at the Lean Six Sigma and patients, particularly in relation to quality, risk and outcomes and patient experiences, and one of which is looking at them at a more organization and leadership level. So those 2 pathways are being looked at and not being ignored. And they're in about year 2 and 3 of their PhDs currently. So I predominantly focused on Lean Six Sigma and staff. And within that, we found 3, if you want, theories or areas for exploration. What were the aspects of the organizational culture in which staff were working? How did the organizations respond to Lean Six Sigma when it was launched? And how did staff who were Lean Six Sigma practitioners see themselves? And this was enabled us then to go into the study site and to work with interdisciplinary staff across all grades. And just to say, these were clinical grades like physios, OTs, nurses, radiologists, etc., but also medical secretaries and porters. So it was very equitable across all grades. We had one of the hospital health services states painters on the team who had trained in Lean as well. So it wasn't just for clinicians. We were very clear that anybody could involve, because everybody is part of the hospital system, the wider system site. So we were able to do that. And from that, then we were able to take the findings from the realist review and look at the work that was already out there, obviously existing models, in particular Brendan and Tanya's work, and then look at the work Brendan and Jan Dewing had carried out around the COSI model, where this process improvement line that to develop the person-centered Lean Six Sigma model. And basically the model then that we were testing enabled us to develop what we call context mechanism outcome configurations. So we were able to say, what about, and there was, just to say, this is just one example, there were multiples of these within the study. We were able to say what contexts lean worked or didn't work in, what were the mechanisms that made staff engage with it or not engage with it, and what were the anticipated outcomes. And when we had all of our theories matched, we went back to the study site and we asked the practitioners who were practicing lean in their local practice areas to look at the model and to look at what makes lean work or not, and to map where they felt it worked and it didn't work. So very much the whole time in the realist review, you're adjudicating the theory. So you've got 6 levels, in this case, 6 levels of adjudication between your different levels of an expert panel, a reference group, your realist review, and then you're going back to your expert panel, but also you're getting the practitioners, the people who do the job basically are adjudicating it. So that enabled us then to develop our model. And very much, we focused on where the synergies were. So the synergies were very clearly in relation to the voice of the customer. So talking about customer voice, observational studies, which they call in Lean Gemba, go to the place of work. The concept of respect for person. And if you go right back to the philosophy of Lean, the original philosophy of Lean talks about 3 things: respect for person, consensus and decision making, and harmony. So the Japanese culture, which was feeding into Lean, had become very technical in its adaptation into industry, but then that transferred over to healthcare. So how do we get back to that respect for person, and then staff empowerment, all inherent in person-centered approaches. But then when we looked at the divergences, we could see that, you know, things like core values, what Lean and Six Sigma don't look at people's values and visions for the service. They don't start by doing that visioning piece. The first principles are different. The principles are more about, you know, turnaround time, metrics, how people get on, how many patients, how much money, et cetera, et cetera. And then standardization, where everything has to be standardized. So one of the things we really found was that in industry, it says basically, in Lean, it more or less says, and in Six Sigma in particular, standardize everything. But what we realize, obviously, in healthcare is you have to have variation across different specialities, such as oncology, surgery, you know, all the different pathways within medicine, so that you need to have variation. And so we very much write about unwanted variation as opposed to variation. So we developed the model as a lens, and it really is reflective. Now, one of the key learnings for us here is when we were working with groups of nurses, lots of nurses are trained in reflective practice. But when we would go to work with groups on the ground of multidisciplinary teams, they don't really practice self-reflection. And that's with no disrespect to any of you who come from backgrounds outside nursing, but it's not the norm for people to do reflective practice. So we really had to design then reflective practice training for people to get them on, you know, to provide that on site in local hospitals, that people would understand what we meant by that. So very much it's designed as a model. And the model, just to say, I'm not going into it in too much detail now, but it is like a 25-page booklet that you can take. But really what we're trying to get people to do is, yes, manage by fact, but to use meaningful metrics. So for staff, what does it mean? Here we are during COVID in April 2020. I was asked to lead a team in the COVID clinic in the hospital. And here I am working with the team, and we're all clinicians. And they said, let's take a picture of your team. And we said, that's great. And then I said, no, hang on, this isn't the team. These are the team members you can see. So if you look at this, this is the team, a wider team. And all of the people here are the hidden team that you don't see. So these are phlebotomists, these are pathologists, these are the people doing the COVID tests. So you can see immediately the team is much bigger than you think. There's what you see, and then there's the hidden work that goes on. And often these people are unrecognized. So to be really person-centered about improvement, you have to make sure everybody's seen. You have to make sure everybody's visible. And all of these people who have the orange circles on them, they are people who are trained in person-centered approaches to improvement. So we were very lucky to have a team of with these mentors within it to enable us to get the clinic up and running in a timely fashion. So this is just some feedback from data we have from staff who've involved in work using the model in different study sites. So you can see here, by refocusing to put people at the heart of decision-making processes, we enhance the quality of care while fostering trust, empathy, and collaboration among healthcare professions. Person-centered principles ensured that our improvement efforts were guided by the fundamental goal of improving lives and experiences. That was a dietitian. The model highlights that all change improvement efforts are limited to metrics and demonstrate clearly how person-centered soft skills can generate a significant long-term impact on improved initiatives. That was a quality manager. And last one was from a physiotherapist, which was quite interesting. Now, we've lots of this. I just pulled some data out for you. My default condition, often and particularly for this project, was to know the solution that we needed to get to without respecting the process and, more importantly, the individual. Thankfully, through insightful team members and reflecting through the model, we developed a more respectful, person-centered approach. So from a staff point of view, we can see that the model is working for them in practice. But what does it look like for patients? So if I just take Arnstein's ladder of system participation, I'm sure many of you are familiar with it, moving quickly through it. We're trying to move patients, you know, from that therapy piece, and this isn't linear. Really, it should be linear. It's a ladder. It's hierarchical. But really, how do we get patients to the point where they're in control? So we talk about PPI, or patient engagement in projects. So how do we use our model of person-centered lean to ensure that we engage patients and that our engagement with patients isn't tokenistic? So just give you a couple of very quick case studies. I'm aware of the time. So this project is a project with cardiac investigations. And you could see what they were trying to do was they had a 133% growth in patient follow-up since 2006. And there was lots of patients turning up for on schedule. So basically, this was a clinic where patients were having implantable devices, and the capacity was far out, demand was far outstripping the capacity. The staff felt that this was unsafe. It was compromising patient care. And they felt they did not have time to follow up properly. So what we did was we involved patients in this. And basically what we did was we got the patients to, we asked them to get involved, and we said, what would you like to do? So they reviewed and improved the existing patient guidelines. This is them here in orange. They reviewed and improved the guidelines for remote monitoring patients based on their lived experience. The patients held patient workshops, so with no staff present, so the patients facilitated their own workshops, and they understood and agreed the goal of what the goal was for our project. From a point of view of staff, what they did was they investigated the same thing, but from a staff perspective, they reviewed and improved the guidelines, and then co-designed new guidelines with the patients. They investigated the impact of current state of the service on staff, and they understood, so it was common goals between patients and staff. And what they were able to do was they were able to have, this was our first working use of the model when it was still in, I suppose, draft phase. You can see that they were able to have a 194% increase in remote monitoring. So with a 70% decrease in the activity in the clinic because less people were just dropping in, and they've sustained 7 years post-implementation. So it was really working for staff and patients there. The next one then was in relation to pediatric cardiology. This came about because a child travelled from Kerry in Dublin, Kerry down here up to Dublin in 5 hours. They waited 4 hours in clinic, and they spent about 6-7 minutes with the consultant. This was in pediatric cardiology. The parents, this happened twice, and then the parents complained. The child had multiple, had Downs as well, and had multiple comorbidities. So basically, what we wanted to do here was involve the parents again. And you can see that basically what was happening here was children were coming in, and the process map shows were going back and forth and back and forth and back and forth. It wasn't a linear process. They're spending most of their time waiting in the process. So what we did was we asked the question, if a child, and we asked parents and older children and staff this, if a child was a train that had to go from Dublin to Belfast, for those of you, that's on the east coast of Ireland, why is the child stopping at every stop? So for example, one of the things we found was that every child was having an echocardiogram. Well, we said, why are children having an echocardiogram? Do they need them? No, but we've always done it this way. But is that what they need? No, so we need to redesign this process to make it work for staff, because staff were, the clinic was starting at 8 o'clock in the morning, was meant to run till 1. It was running till 2:30. The next clinic was meant to start at 2, was starting at 2:30. So there was lots of patients waiting longer, and staff weren't getting their lunch break. Seems like a small thing, but a big thing. And then staff were working late. So how do we make this work for everybody? So this is pre-intervention, and this is post-intervention, where children only went to the stops where they needed to go. And basically, as you can see here, what we have is, this is the what we call value-added time pre-clinic, and this is the non-value-added time pre-intervention, and this is value-added time post-intervention. But this is the main thing. Look at how long the clinic runs before, and look at how long the clinic runs after. So what did we do to make this work? Well, what we did was we asked staff to look at the impact of the clinic journey on the clinic on child and family journey. We investigated what was the impact on staff by the staff, understood what constituted this non-value from both colleagues and patients, and changed the way they worked, and used new ways of working to inform other clinics within the service. And then the parents carried out observational studies. They reviewed their own data. They carried out 5 why exercises to understand the clinic flow, and they collaborated with clinicians in co-designing the new clinic flow. So we reduced our non-value add by 200%. The clinic had an average overrun of 90 minutes. Following the intervention, it ran on time from 8 to 1 p.m. and a 24.24% percentage decrease in the overrun. So they were co-designed using a model of improvement that is person-centered, that works for both patients and staff, and obviously has a big bang for the organisation as well, because the clinics aren't running late. And then the last case is just a case in relation to diabetes. This was another hospital we work with in the south of Ireland, and this was where children who were moving to paediatrics. From pediatrics to the adult service, we're having a lot of adverse incidents in diabetes. So we could see immediately that, you know, that of 60 young adults with diabetes, 37% were defaulting under self-care. 42% of them missed an average 4 appointments in 24-month period. And they were being sent to a pediatric service into an adult service. So what the hospital did was they set up a pediatric service, but they didn't consult with the young adults. And just to say, they call themselves young adults with diabetes. They didn't consult with them. So they set up a clinic with nurses, doctors, dietitians, and nobody turned up to the clinic. Not one young adult turned up to the clinic. And when we start engaging with them, things like, well, why do you have a clinic in the afternoon? We want to go to the clinic before college or before school. Why would you have it in the afternoon when we're tired? Your Wi-Fi is crap, pardon my French. You've no water cooler. We need a room where we can meet. They're adolescents. So none of that was taken into account. So obviously we looked at the journey of diabetes, working with them. And what we did was we got them to do their own work again. So they participated in the survey, they participated in focus groups, they process mapped their own individual journeys, for example. They carried out their own surveys and analysed their own data. They used 5 whys. They used a tool we use in Lean called Scamper to produce a high-level design of the new service and presented it as their vision of the service to staff. And they collaborated with clinicians into co-designing. Just to say, we told them at the beginning, we've no money, we've no budget. So when you're designing, keep it cheap. We're very honest. There's no point in promising the sun, moon, and stars. The staff delegated power to the young adults to design their own service. They investigated the impact on staff. They listened and showed respect to the young adults. They worked as a team to secure the resources. They then got funding from pharma to fund some of the stuff that the young adults were asking for that had payback on it. They commissioned the service, and they followed up with second generation community outreach. So that's just an example of how we've used the Project Muse, where you can move I suppose it facilitates that model of a more democratic approach for both patients and staff, and it's worked very well in that regard. We've then integrated, so theory from learning for practice. We've integrated the model into our curriculum. We've integrated person-centered principles and a teaching model into each of our 3 process improvement modules as well, where students are continually exposed. So we've really made sure that we now teach person-centered improvement as opposed to Lean or Six Sigma. And we've even changed the titles of all of our modules. It used to be called Lean Six Sigma for healthcare, and so we changed everything just to reflect a more person-centered approach. And we've learned from, and I just see Emma there earlier as well, Emma Hyde. We've had some fantastic input from people like Emma, and thank you, Emma, with their MOOC, their online open access, and got some ideas off that as well. So thank you. It's always great to build on people's work. So that's sort of where we are with the model at the moment. The model is in use now in 7 countries, 7 sites in different countries. We're getting feedback from all of them. It's predominantly qualitative feedback, but we are looking at how it impacts and how staff work, and then the impacts on patients as well. You can download the model. There's a link in this which you'll be able to click on. We'll get a PDF copy. You can email us if you'd like a hard copy of it as well. if you're interested in that as well. Just to say a huge thanks to our partners. We're recently delighted that Children's Health Ireland have come on board with the model as well. So they're adopting that in 14 sites that are looking at pediatric retinopathy of the neonates as well. So we've been doing a lot of work with ophthalmology, but we've had a lot of partner sites building in. We've done a lot of work with Vision Ireland, funny enough, who have been very interested in that as well. So I hope I haven't run over time. Apologies if I have. There's references there as well. And I've just got a couple of questions there as well. And I suppose the key thing is that I just to sort of frame these questions. One of the things we found a lot when we're talking to staff during this research was that staff feel that their work is judged by volume. And when I talk about being judged by volume, as in how much of this have you done, how much of that? And I'll just tell you a very quick story. I'm sorry, I'm watching the time. A very quick story. And this story is that I had a student who was doing a master's and he was doing an improvement project. And he used the model for his improvement project. And he was trying to improve the flow in a heart-lung transplant clinic. And every Thursday, 28 patients turned up to the heart-lung transplant clinic. And after a year of his program, he went back to his hospital and he was working with them. And he said, I'm really, really interested. He said, here's my results. And his CEO and his director of nursing and his COO said, what's going on here? You had 28 patients in your clinic on a Thursday when you started your master's. And now a year into it, you've 28 patients at your clinic. There's no improvement. And he said, why? And they're going, well, you've still got 28 patients. And he's challenged them and said, you're looking at metrics of volume. How many patients? How many patients? He said, how much of it? He said, look at the metrics. He said, when patients first came to my clinic, he said they would come on a Thursday and they would wait 40% of their time waiting, 10% of their time with a clinician, which was an average of 9 minutes. And they would return to the clinic in 6 weeks because the clinician didn't have enough time to spend with them or they didn't get all their tests done. So he said, now, post my person-centered improvement, they spend 10% of their time waiting. They spend 20 minutes average with the clinician. It's an all-day clinic, either an AMP, a nurse, advanced nurse practitioner, or a consultant. And the consultant or nurse says to them, come back in 12 weeks because I spent enough time with you that I don't need to see you in 6 weeks. And they have time for whatever tests they need, pulmonary function or whatever. So he said, you're reading the wrong metrics. The metrics to look at are time spent waiting in clinic, frequency of patient attendance, and time spent with the clinician. He said, you are judging me on volume-based metrics. I thought that was a great example. So I've sort of focused the questions around that. And the two questions are, and I know there's going to be breakout rooms, but you can pick either question in them. How can we shift our focus from volume-based metrics to person-centered outcomes? And what specific changes can we implement to ensure that our practices enhance individual well-being and satisfaction? And this is really to encourage you to think about current metrics used in your work and explore practical ways to align them more closely with the values of person-centered care. And the second one is, how can we effectively integrate holistic person-centered care approaches within improvement methodologies that emphasize standardization, ensuring that individual patient needs and preferences are not overshadowed? Because one of the things that happens with process improvement methodologies is they talk about standardize. Yet the dichotomy is we're meant to deliver holistic person-centered care. So how do we make it work? So really there's two questions there that I've popped up that I know Shima is going to put in the chat. That would be, I'd be very interested to see what you think, your experiences of them, because everything feeds forward into the work we're doing. And that's, thank you so much for your time and attention. Thank you, Caroline and Christoph and Shima. I'll shut up talking. Thanks very much. Thanks, Shima. Well, I very much feel this is really self-directed. It's really yourselves I want to talk rather than me talking at you, to be quite honest with you. So this for me really is just two questions that come up. Just that last example that I gave you of that particular master's student in relation to the heart-lung transplant clinic and those volume-based metrics. But more and more, my experience was that, as I say, the volume-based metrics were people were being judged on outputs that were just related to that. So I suppose another one I'll drop in, then I'm going to stop talking amazingly, is, even I would challenge in Ireland, we talk about patient experience times, which means patients coming into our emergency departments are meant to have 3-2-1, 3 hours, 2 hours, and 1 hour, and they're meant to be out of the department in 6 hours, either moved to a ward or discharged. It never works. But I always challenge. I say, how are they? That's not experiences. They're times. You could be out of there in 6 hours, but you could have a terrible experience. That's just measuring time. There are time factors. It's how we name these metrics. It's how we use metrics. Is really what I was trying to get to with that question. And then the second one was really about where a lot of improved methodologies just say standardize across the board. They don't allow for that individualized, personalized care. And that's what the model, and trying to build on the work of Brendan and Jan and the COSI model, trying to locate it to somewhere that's more person-centered improvement. So really that's what those two questions are about. So I very much welcome, rather than me moderate, just I suppose that just to explain a bit more what I was at there, just welcome people's thoughts and discussion on that, because for me as well, I welcome any thoughts or ideas that can feed into the work we're doing. Joanne, hi, how are you? I see you have your hand up there. Thank you.
Thanks, Jean-Paul. It's Joanne Bosen-Kay. I'm the Chief Executive at the Foundation of Nursing Studies, and Happy Learning Disability Week to everybody. So yeah, do you see me? That's quite an interesting thing to have in my I didn't mean to do that today, but so yeah, we've just had a great session with Andy and Emma, and kind of learning from what's happening up in NHS Tayside, well, and Scotland really, around the minimum safer staffing and the 12-hour shifts, because what we don't do very well when we are introducing legislation is to look at potentially what could go wrong with it. And so, I mean, Andy, come in. I don't want to talk for you, but that for me really, I mean, straight away resonated with me about something that's actually happening, that England are kind of fast followers of potentially, but we're not learning from kind of, you know, the negative consequences of doing things like that. So I thought that might be worth us having a look at, because Andy's got and Debbie Bordy's got experience of it kind of right now.
Yeah. Thanks so much, Joanne. Appreciate that. Andy, did you want to elaborate?
No, we were just sharing experience about, you know, the programs that we run, you know, up here, and what we do, and, you know, the problems with in around attendance, you know, and around these sort of things, you know, or even the uptake, you know, it's got people sign up for things, then can't attend because of the difficulties that they have, and around, you know, 12-hour shifts and, you know, minimum staffing on wards and all that. And these are problems we're just beginning to sort of unpick and choose just through sort of ad hoc conversations around, you know, around these things. But like Joanne says, it's about, you know, trying to figure out how best to get these things to people, you know, that they can make the best use of the things that we're putting on. But there are things in the way that we probably just don't fully understand yet, as the consequences of other things that we have no control over. Complex.
Yeah. Thanks. Thanks very much, Andy. Appreciate that. One of the things we pull from where I suppose some of the improvement methodologies are useful for us is where you scope your work. So for example, when I have teams of students and they say we're going to do an entire hip fracture pathway from door to door, and I say, well, you're all working full time, you've all substantive posts, you're doing this as part of a program, would you not build it into smaller pieces of work and make it more manageable for yourselves? I think sometimes that's where our role is just to support, well, certainly my to support students and to make sure they don't bite off more than they can chew either, and that it's in type of the small, which people often overlook. I think management often overlook. They introduce something, but the power of small incremental change, small bits of change, rather than like one whole, this is the new shebang and get stuck in, basically. Sorry, my Irishness. Brendan, sorry, apologies, you had your hand up.
No, that's all right.
Nice to see you, sorry.
You too. I wanted to bring us back to the measurement thing as well in that context, and I know that whole issue of shift patterns, etc., is a real challenge in relation to actually making things happen. But in particular in relation to measurement, I guess there's a huge level of frustration always in relation to this, because for 20 years we've been saying and writing and showing that you cannot measure person-centeredness, person-centered care, person-centered culture with any one single measure. And that you cannot reduce it to a single indicator and measure that, and then say, yes, we're person-centered or we're not person-centered, because actually we're talking about a whole different things. And philosophically, of course, what we're trying to do is apply a technical, rational, positivistic view of the world to something that is humanistic and relational. And so in principle, that's impossible, but yet we keep going around this circle in trying to make that happen, as if somehow we will one day land on the magic bullet that is the indicator that tells us all that, yeah, we're all person-centered, which is a total load of, to use your phrase earlier, crap. And what I would want to say is, we have been showing that you have to combine essentially what we could now call lived experience data with process data, with standardized outcome data. And it's the combination and the analysis of the three that gives you some sense of what is person-centered or not person-centered. And of course, you would know that, Jean-Paul, from a realist perspective, because you can have as many outcome criteria as you like, but if you don't have a thorough understanding of the contextual factors that lead us to that outcome, then they're meaningless. So I just want us to get away from this thing that somehow we can land on this magic bullet of a single indicator that will tell the world, or Hannah may want to say about her conversation, or tell the whole of Sweden that suddenly you're person-centered. It's tosh and actually philosophically incoherent. And my point of raising this is that I think one of the jobs we as an ICoP have is to challenge this thinking and not just buy into it. And there's a great danger that we just blindly walk into it and get sucked into it in our research and our work because it seems like what everyone wants, when it's absolutely incoherent, philosophically impossible, and actually methodologically flawed. And if we're going to be a movement, then we need to challenge that thinking in the first place at a systems level.
Thanks very much, Brendan. I really appreciate that. And yes, actually, as you say, from the realist point of view, I completely agree with the contextual factors and that understanding as well. Yeah, and I think that's hopefully what we're trying to do, certainly in relation to the improvement, is to it's a very much, as I said at the beginning, it's a lens that it's reflective for the individual to reflect, rather than say, the usual tick spoke to patients, tick spoke to Brendan, tick spoke to Hannah, says tick spoke to, which is often what you just get a tick box. So very much we wanted to design a building on reflective practice, but I completely agree with Brendan, and thank you for that. Appreciate that. Tanya, I think you had your hand up. Sorry, apologies. Morning.
Hi, Jean-Paul. I really enjoyed your presentation this morning, and I just want to follow in behind Brendan. I think he kind of gave that lead into me. I think he just set me up very nicely. So I've done a program of work, led a program of work around the development and implementation of 8 person-centered nursing and midwifery key performance indicators, and these actually measure the person-centered processes largely within the person-centered nursing framework. They are nursing and midwifery specific, and I make no apologies for that. And they actually just feed in right to what Brendan has said. These are indicators that are implemented at team level. They generate evidence for that team to think about their practice and how it is influencing the experience of care for everyone. Because obviously, whenever you are able to engage in effective, really high quality care, there is something that lights a fire in a practitioner who wants to give the best of themselves. So this work has been on for 10 years. It's been KPIs have been developed. There's been a proof of concept study published. We've developed an app alongside it, and we've done 4 implementation studies. And they do what Brendan says. They capture the complexity, not all, but key components around the complexity of person-centered practice. And I have been continually drawn in at a national level around metrics. What should they be? And there's a lot of discussion going on at the moment around that. And people are trying to place it within a kind of an excellence framework notion, as opposed to assurance. And I suppose the argument I would make is it's not one definitive measure. We need to think about our traditional metrics because they're an indicator of quality clinical care. We have to think about person-centeredness metrics that tell us something about person-centeredness, metrics that tell us something about how is the organization supporting their workforce, retention, recruitment, etc. So it's a matrix, and it's never one definitive measure. So I would agree with Brendan, but certainly the nursing midwifery KPIs are implemented at team level to drive quality improvement. And I would suggest those metrics aligning with some of your work, could be very interesting.
Very good. Thanks, Tanya. Definitely be getting straight on Google after this. I really appreciate that. Actually, interestingly, just Tanya, when you say that, I was involved in a study with I wrote the Realist Review piece I led on that between DCU, Dublin City University, UCD, and University of Limerick, and we were doing an analysis of the deployment of the nursing midwifery quality indicators in the Republic of Ireland. But one of the things was, it was realist, but one of the things was when we were doing the interviews for the evaluation part, it was very much looking at the metrics, but exactly what you said, what was coming back, and people kept saying, what's this coming back? Staff were talking about factors like having a facilitator, having a champion. The word champion kept coming up. It was nowhere in any of the questions, but it was coming from around the country. And it's interesting. So even though it wasn't sort of sought, but probably because we were doing realist, these themes were surfacing that obviously were very dear to nurses and midwives. You know, they needed these supports, because when I trained in the NHS years ago, you know, you had a clinical facilitator, and I trained in London, you know, you had your you always had somebody coming around, and they sort of disappeared off the wards, and you know, they were another. So a lot of people were talking about those type of roles that didn't exist anymore. So I thought it was quite interesting. The stuff came out, but I'm definitely I'm very, very interested in that. Tanya, obviously, I'll be dropping you an email.
If I just come on the back of that, some of those mechanisms you're talking about are actually part of, if you look at some of the implementation science frameworks that are emerging, because actually those kind of strategies we're actually looking at more closely in the implementation study we're doing at the moment around large scale testing of the newly developed app. So you're totally right. That's actually part of this is also about how we integrate implementation science into some of this activity. So absolutely on the same page.
Yeah, great. Thanks, I appreciate that. Brendan, apologies, you have your hand up there.
No, sorry for it. I wanted to come back on your point about the champions. And obviously with my background that most people on here know, then obviously, you know, the development of facilitators and that kind of role is something I've for a very long time felt very passionately about, and which we've neglected hugely. But actually, I did want to make the connection between what you said, because I think I've shifted myself quite a bit over the last few years around that. And I think the work that Caroline and I did in the Heal-In Leadership Project, which is a realist project as well, and one of the key characteristics of an effective person-centered leader who was focused on developing healthful cultures was visibility and availability. And that was all about, exactly as you said, people who are visible and available, who can facilitate as part of their role, who are, anyway, you can talk about it, Caroline, I gave you the lead in. But actually, so what I'm saying is, I no longer am convinced that developing specific roles is the right way to go, that what we really need to focus is on how we shift the lens on leadership so that the leaders are the ones who are doing that work in a visible and available way.
Thanks,
It's only taken me 30 years, but hey, I'm a slow learner.
Thanks, Brendan. Caroline, did you want to?
Well, I suppose just, and I realised, Tanya, you've got your hand up there, but another of the practices was about being prepared. So preparation is important. We can't just expect people can facilitate in this way. So we have to pay attention to that, and I think that is hugely neglected.
Yeah, thanks very much, Caroline. Appreciate that.
Paul, can I add, it's Debbie. I just don't know how to put my hand up on Zoom. Sorry.
Hi, Debbie. How are you?
There's no one else's hands up, is
I
there?
did mention you earlier. No, you're good to go.
I saw that. Thank you. Great work. One of the things that we just talked about in our small group, and it was just to, you know, we in ICoP we recognise that definition of person-centeredness being different to patient-centeredness. And I think another area of our work, that second question for me, the answer is back to that facilitation. So we, in our quest for reducing variation in healthcare, we have, you know, really strict processes of communication, handoffs, all that kind of stuff, which sometimes are excluding our own staff, and nobody's paying attention to that. So I was sharing with Tanya around a neurodivergent, newly graduated nurse who's working in the surgical theatre environment with a surgical pause, which is quite right to do, to ensure that we don't take the wrong limb off and all that kind of stuff, ensure the team are ready to go. But it's done so slickly and so fast now that she can't keep up. because of the way that she learns and the way that she you know, brings in information into our system and makes sense of it. And actually, if we're not paying attention as facilitators to, is that new way of working for all of the time? It's not safer, it's not more person-centred, and we're not paying enough attention to that stuff that Brendan and Tanya were talking about, the process evaluation stuff, which I know that's been a big part of your integration into your model. Is yes, this works better for patients, but is it working better for us, and is it sustainable, and is it enhancing our integrated, interdependent ways of working that are respectful of all people's needs? Because when I shared that story with a colleague, the first thing they said to me was, well, should she be in that environment? Is she safe to be there? As if it's her fault. And it's no, the context is not enabling her to be at her best. She doesn't have a learning difficulty. She's a fully competent graduated nurse, but we're not creating the conditions for her to be at her best and to be at her safest. So I just thought, bring it back around from the patient through to the whole person-centeredness. I thought it was it's a real brave space that she's going into and challenging that, and hopefully we're going to get her to do her PhD around it, but it's another thing. But thanks.
Thanks, Terry. Really appreciate that. Thank you.
Can I just bring this to a close? I'm really, really sorry. Just we try to be on time. Sean Paul, can I thank you so much? You've given us all food for thought, and thank you for all those questions. I think that biggest question is, you know, in trying to make things better for people using and experiencing our care, how do we also make it better for those who are caregivers? And so hopefully we'll take that away. So just to finish off, I just want to remind you of the next webinar. Hopefully you can see that is the 18th of September, and that will be around a person-centered curriculum. Hopefully you like the format today, that you got to connect in smaller groups as well as in the larger group, and we will continue on that theme in September and the 21st of November. Just a wee reminder that we do have the Teams site that you can connect together as well. So please go on there through the website. And also, if you're not a member, please join us through the website as well. And I think I've covered everything. Have I, Christoph, or do I need to say anything else? I think I've covered everything.
I think you covered everything, and thank you very much to
Okay,
everybody who
thank you.
joined. Thank you.
Yes, thank you for coming, and we'll see you next time.
Thank you. Bye.
Goodbye.
Bye.
Thanks, folks.